Start, ma'am. We are live.
Namaskar and a very good evening to one and all present here. I welcome you for the webinar on lung cancer update. And with immense pleasure, I would like to invite Dr. Aditya Murli, who is Senior Consultant Medical Oncology, Hemato-Oncology, and Bone Marrow Transplant, Apollo Hospital, Bangalore, for the welcome and introductory note and to set the ball rolling. The stage is all yours, sir. Over to you.
Thank you so much. A deep round of thanks to the organizers, to AstraZeneca, to Guardant for arranging this webinar. It's a Friday evening, and I would like to convey my heartfelt thanks to all of our esteemed colleagues who have joined in just before a long weekend so that we can discuss something exciting about lung cancer. So from a very personal point of view, lung cancer has been an area of interest right from my postgraduate days time, wherein I had chosen this as my thesis topic. And then the 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 most interesting part about lung cancer is that this is like general elections in India. There is always something new happening. Just like parties change or the candidates change, the molecules also change given the circumstances. And to discuss all of these new changes, we have a whole list of superstars amongst us today. It is with immense pleasure. Let me invite Dr. Abhay, Senior Consultant at Manipal Hospitals, Bangalore, to deliver the first talk. Abhay, over to you, please.
So I'm unable to do screen sharing.
Organizers, yeah, great. I think you should be able to do now, Dr. Abhay.
So my slides are visible?
Yes, sir.
Slides are
Yes, sir,
moving?
it is visible. Yeah, it's moving.
Thank you, Aditya, for a nice introduction. And at the outset, I'm thankful to AstraZeneca, Guardant, and Zydus for this opportunity. So I'm today talking about the importance of NGS testing. So is it mandated for all patients, especially in lung cancer? So like NGS is like one of the exciting topic in recent years in lung cancer. So we know that patients who are having oncogenic driver mutations carry a better prognosis, whether they are treated with targeted therapy or not targeted therapy, compared with the patients without a driver mutation. So this is one data where the overall survival benefit is much higher when a driver mutation has been treated with targeted therapy. So compared with the patients who have not who don't have any driver mutation. And also there is a still patient with driver mutation who have not even been treated with targeted therapy. Also the overall survival is better compared with the no driver mutation. So the tissue testing for in NSCLC includes various methods. So we started using IHC, FISH, PCR. So now DNA sequencing, NGS. So DNA sequencing is again the NGS is a part of DNA sequencing, and also Sanger sequencing. So DNA sequencing, NGS, and with PCR, we can able to detect insertions, point mutations, and deletions. So commonly what aberrations we detect in lung cancer? So by these methods are EGFR, KRAS, BRAF, HER2, MET exon, MET skip exon 14 mutation, and there are different ways of screening them. Either we do one after another, that is reflex testing, that is single gene, or a full NGS panel. So most of these mutations, all these are detected by DNA NGS sequencing, but the fusion abnormalities rearrangements, so most is picked up by RNA-based NGS testing rather than just DNA NGS testing. So with this, we can screen for ALK, ROS fusions, NTRK fusions, and RET rearrangements. So lastly, about the IHC and FISH. So IHC and FISH we are commonly using since earlier for ALK and ROS testing. So usually IHC is a very simple, easy test, less costly, which detects ALK and ROS, but it is not very sensitive. Fish is also very highly sensitive and specific, but it is unable to detect the fusion partner. But it can be faster also, but it is unable to detect the fusion partner. So there are different ways of screening them. So that is one is reflex testing, first for a second gene, then subsequent gene. So that is what we used to do regularly. So nowadays we are moving towards next generation sequencing, where we screen for a broad-based panel and simultaneously. So there are both advantages and disadvantages for both, that is single gene testing as well as broad-based panel NGS testing. So as the number of clinically actionable biomarkers has been increased, so we are to evaluate all known molecular alteration in a single test. So NGS has a major advantage. At a single test, at a one stretch, we are trying to identify molecular mutations in different kind of genes. So if we are planning only single gene or few molecular markers, then single gene test is the way to go, because it is associated, it is a less costlier and also takes less time compared with the NGS test. But when you are planning for a broad-based panel, so then obviously NGS is the way forward, because it is associated with so less cost, shorter turnover time, and less tissue requirement. So NGS has both advantages and disadvantages compared to the single gene test. So NGS is highly sensitive and specific and more reproducible, and it detects a broad range of molecular alteration in a single sample with a less availability of a tissue. And it may also identify new markers, which can be many times targetable, and also provide information to help the development of new and more effective treatments. But there are also associated some disadvantages of NGS, that so NGS has got a very high complexity of workflow that requires more expertise. So performing the test and also interpretation of NGS results. So this is one study which has been shown that when NGS has been compared to PCR when screening for the EGFR. So we know that, so we earlier used to use PCR for screening for exon 19 and exon 21L858R mutations. So this PCR can detect even uncommon mutations, exon insertions. But there are some uncommon mutations are missed by PCS, and also some variants of exon 14 variant. So this is a one study which has shown that around 48% of the EGFR exon 20 insertions which are identified by NGS are missed by PCR. So there are around 17 most common EGFR exon 20 insertion variants. In that, this PCR can able to pick up only around four type of variants. So the ROS1 is also can be picked up by NGS, basically by the RNA-based NGS, which has a high sensitivity at 100% and specificity of 97%. So by doing NGS, we can able to identify novel translocation partners, so which are inherently not possible by FISH. By doing hybrid capture-based NGS in a cohort of patients, so in one study, we found out that ALK was around, ALK prevalence of ALK is around 4%, and that of ROS is around 1.5%. NTRK fusions can be detected by all these three methods: IHC, FISH, and NGS. So IHC and FISH, we get the rapid results, but IHC has an advantage that it is a low-cost single test and widely available, and detects only transcription and translations only. So disadvantage is that the depletion of a tissue. So we unable to know the fusion partner and also position of the fusion. So same disadvantage with the FISH. In the NGS, the advantage is that it can be screened along with the broad-based panel and less depletion of tissue. And here also the fusion partner and position can be defined. So as I told, RNA NGS is the way forward. That is the one which is most sensitive to detect the fusions and rearrangements. The disadvantage of NGS is only is that long waiting period, at least around 2 weeks. So and hence the choice of assay will always depend upon the institutional practice. Some institutions still prefer reflex texting, and some institutions prefer broad-based. They move to already broad-based NGS panel, and also the availability, that is a resource, and clinical context, whether you are testing in the first line setting or next line setting. So the principles of molecular and biomarker analysis is that there are different NGS panels. So as I told earlier, there are DNA NGS assays and RNA NGS assays. RNAs usually pick up the rearrangements, fusions. DNA NGS is usually picks up mutations, deletions. And the NGS, there are also NGS broad panels like 50 gene panel, 100 gene panel, 150 gene panel. And similarly, we have also NGS based upon the disease, that is a lung panel, where we commonly screen 12 genes, and we have also colon NGS panel, where we screen KRAS, NRAS, BRAF, HER2 mutations, and MMR. So like that. So whenever you order for an NGS, covering what you are looking for. So what type of mutations you are looking for, whether that whenever you are ordering for an NGS test. So the NGS test has also role in the setting of progression of in the setting of post progression on targeted therapy, especially in EGFR anti-EGFR therapy. So whenever a patient receives first line or second line anti-EGFR therapy, so the most common mutation we know is that T790M mutation. So in that one, single gene panel is enough to screen for that one. But whenever, if that is the third generation EGFR TKI, we know that there are various mechanism of resistance, that is MET amplification, HER2 amplification, and KRAS, BRAF mutations, PIK3CA mutation. Osimertinib, the way forward is a broad-based NGS panel to look for the potential mechanism of resistance, so that we can overcome that resistance, which many of them are targetable, like MET amplification, HER2 amplification, PIK3 mutation. And sometimes in such situation, a person may require multiple times NGS. If a patient progresses on again second line, if a patient progresses on line, so multiple times it may require in a one set of patient. So this is one of the study of NGS. This is one of the study of NGS from our own Indian data, so which has been presented in ESMO 2022. So this is from Rajiv Gandhi data. So where they continuously consecutive 414 patients have been screened for both single gene assay and NGS assay. So they use both DNA and as well as RNA assay. In that assay, they found EGFR mutation in 36%, KRAS 30%, BRAF 5%, RB2 in 6%, ALK in 6%, RET 6%, ROS in 2%. So compared to the sequence negative patients, so here through the NGS, they can able to detect 1.2% additional actionable mutations, and also with the median time duration of around 14 days, 14.2 days, and with incremental cost of 19%. So in this study, the cost increment was 19% because they only screened for these genes. But nowadays, since when you are screening for multiple genes, the cost may even come down. So the other interesting findings they found is that this NGS, they can able to identify complex EGFR alterations, variant ALK fusions, as well as ROS1 fusions. So the other interesting finding in this study was that in patients with squamous histology, they depicted MET exon 14 skipping mutation in around 2%, and KRAS G12C is detected in 4% of the patient. So they concluded that this study underscores the need for upfront NGS testing despite increment in the expenditure for the patient. So our results support the implementation of diagnostic NGS in NSCLC to allow patients access to most appropriate molecularly targeted therapy. So these are the expert consensus recommendations on biomarker testing in metastatic and non-metastatic NSCLC in Asia. So here the majority of the Asian countries experts have been invited, and they formed a consensus statements about regarding testing this. So even we can see that our Indian experts are also there in this consensus recommendation. So they recommended that in patients with non-metastatic NSCLC above stage 1A, so only single gene testing, that is for EGFR testing by PCR is enough, and also PDL1 testing. So here NGS is not recommended. Whereas in patients with metastatic NSCLC, so both are recommended. Either you can use PCR, you can use the single gene assays, that is what we previously regularly used, that is PCR for EGFR, ISC for all, or NGS to cover whenever we are planning for a broad panel coverage. So they also given guidelines for the disease progression. So if patient has already received prior EGFR TKI, that is first, second generation, as I told earlier, minimum testing we should do is T790M. So either through the blood or tissue. So second is patients who has received third generation EGFR TKI. So broad-based NGS panel has to be considered either through the blood or tissue. The patient who has prior other non-targeted therapies, again the way forward is broad-based NGS panel. So patient prior non-targeted therapies, patient received non-targeted therapies. If patient prior NGS panel has not at all test, means we should again, if the patient is adenocarcinoma, we should do multi-panel testing. If the patient is already negative, then no additional testing is required. So this is a one model comparing the value of the broad value of NGS based testing to single gene testing in patients with NSCLC in the United States. So this was presented in 2020. So they did the single gene testing for EGFR leads to large gain in life years at reduced cost per life year gain compared to a single gene test, supporting universal NGS testing of all advanced non-squamous NSCLC patient. So there are also a lot of barriers to the accessibility. Many of us sitting in corporate hospitals and talking about NGS, but in reality, majority of, so there is a large global survey they have done in 102 countries. They found that less than half of the patients with lung cancer less than half will receive the molecular testing. So in 1 or 2 countries, they screened in across Europe, Asia, and Latin America. The major challenge of the barriers are at the level of accessibility, availability, and affordability. So the challenge with accessibility includes the limited number of molecular testing, availability of limited number of centers, and includes the expertise. So expertise in doing these NGS tests and interpretation of these results, and affordability. So affordability includes both. So whether the patient is affordable for testing also, and whether after the patient is affordable for the treatment. So if any mutation is detected. So when to order for NGS test is that, so as a broad-based panel in NSCLC, in metastatic NSCLC, it is indicated, and some advanced rare malignancies or even some common malignancies where available treatments have been exhausted, so we can utilize NGS test. So where and also for any precision oncology, wherever any clinical trials are going on, so in such situation also we can order for NGS. And also sometimes we know that, so beyond the disease, some other diseases, we can see then some exceptional responders also. And then in rare malignancies also, or where the treatment has been exhausted, you can utilize it. So where it is not indicated in early stage lung cancer, if the patient performs take the treatment further or short expected lifespan, so may not require NGS testing. So this NGS testing also can be done. There are 2 ways. One is either through the tissue or through the blood, what we call it as a liquid biopsy. So there, there is different approaches. One is sequential approach, other is complementary approach, third one is a plasma first approach. So sequential approach is the most adequate. The patient will do tissue based So genotyping. When the testing becomes incomplete, then we can utilize cell-free DNA. So that is a sequential approach. Whereas in complementary approach, when we know that the tumor tissue is very scanty and uncertainty about the adequacy of the genotype, where the simultaneously both we can do tumor tissue and cell-free DNA genotyping. And the other way is that plasma first approach. So in that first you have to whenever the usually, so not commonly preferred method. So whenever the tissue is unavailable or the patient is not willing to undergo biopsy or the biopsy is very risky, in such a situation, the plasma first approach is done where cell-free DNA is genotyping is utilized. But again, in this since we know that there is a false negative rate is very high, depending upon the burden of the disease. If the disease burden is very low, if the disease is only limited to brain, so sometimes we may not pick up DNA. So in this condition, so again, if it is a tissue, if the liquid biopsy is negative, we have to do again rebiopsy for tissue genotyping. So this is one study of clinical implication of plasma-based NGS with the delivery of personalized therapy in metastatic non-small cell carcinoma. So here 128 patients, they underwent concurrent plasma and tissue NGS. 54% of the mutations can be detected by clinically relevant, 21% with tissue. So these are the by both combined plasma and tissue, and in the tissue and in the plasma. So they concluded that the plasma-based genotyping for the delivery of targeted therapy in NSCLC demonstrated that liquid biopsy can improve delivery of the therapy. So they concluded that argue for the incorporation of plasma-based genotyping into routine clinical management of patients with NSCLC. So they suggest that, so since considering the plasma-based genotyping, they suggest it can be a routine clinical practice. So ctDNA, that is circulating tumor DNA led liquid biopsy, it can be utilized in the various steps in the management of the lung cancer. So if you consider in the early stage lung cancer, so it is not at all recommended. Only in the diagnosis and for treatment selection, whenever the tissue is not available, biopsy is not possible. So ctDNA is recommended way forward. So there are also that ctDNA can be utilized for monitoring to the response to the therapy, progression or relapse of the disease before the histopathological progression or relapse. And it is done in both early stage and advanced NSCLC. And ctDNA testing is also some major, it has overcome some challenges which is associated with the tissue testing, especially because it is a non-invasive. It can be done serial biopsy we can do so multiple times in a patient's lifetime. And since ctDNA in the bloodstream is comprised of DNA from all tumor sources, and hence it covers both heterogeneity and tumor change. So even though ctDNA is coming up, but still tissue-based NGS is a gold standard. ctDNA is only complementary, which support the treatment selection in patients with NSCLC. So these are the different tests we screen in the lung cancer. There are basically broad-based panel through the NGS. We can cover all these things. So which is both DNA and RNA-based panel. So to cover the mutations as well as rearrangements. So IHC screening, FISH screening for the fusion rearrangements and fusions, and PCR for the mutations. So the broad-based profiling is the key component of the improvement of care of patients with lung cancer, and it is the way forward, and hence it is strongly recommended to go ahead with the broad-based panel rather than single gene testing panel. But again, it all depends upon the availability of resources. Thank you.
Thank you, Dr. Abhay. That was such a lucid presentation. Since we have a couple of minutes with us, if I can ask you just one question, I mean, being the busy practitioner that you are, I'm quite certain that you get multiple people, multiple labs who are trying to say to prescribe this test, that test. Now, we know that, a lab like Guardant or Foundation, they have the wealth of data behind them. But if you have to choose a lower cost option but a broad-based testing, what are the factors that you look at? DNA versus RNA, is it really so big in a practical decision making? That's one. The second thing is 50, 100, 250, 350, 500 genes. Do the number of coverage, does it really make a difference?
See, as of now, what I'm practicing is that disease-based practice. See, suppose if I'm screening lung cancer, I will screen only commonly commonly mutated or tall genes. So that is tumor-based NGS. Presently I'm practicing.
Okay, fantastic. Thank you, Dr. Abhay. I hope you will stay around with us for the panel discussion also. Next, it's my immense pleasure to invite Dr.
Yeah.
Smita, over to you, please.
Thank you, Dr. Aditya. And I'll just share my screen. You should allow me to share the screen.
I think, yeah, it's with organizers.
Organizers?
Yeah. I can see you, Smita. Go ahead.
Yeah, sure. So I'll be talking on the evolution of tyrosine kinase inhibitors. We already had a brief talk on how the importance of biomarkers is in non-small cell lung cancer. So specifically, I think when the initial EGFR, the first line anti-EGFR molecule came, we were all very excited that for the metastatic non-small cell lung cancer, how an oral drug was making a difference. So just let's look at the this has already been covered. So as we all know, lung cancer is one of the most common cancer, almost as commonly 11.6% of the cases. And it is one of the leading cause of mortality, almost accounting for 18.4% of the deaths. And if you look at lung cancer in India, it's the fourth most common cancer among the India and second most common cancer in males. And it is now closely coming to second or third in females also. And if you look at the, it's not that all the patients have a risk factor of smoking. Many of them do not have any kind of risk factors. It's one of the leading cause of cancers with mortality. And if you look at the average age of diagnosis is roughly around the 6th decade with 54.6 years. And it has a male preponderance with around 4.5:1 male is to female ratio. And also the smoker to non-smoker ratio is 20:1. So why are we talking on this non-small cell lung cancer so much, giving so much of importance? Because we know the outcomes have been bad. The overall survival, the 5-year survival rate for the stage 4 lung cancer, non-small cell lung cancer is very poor. So as this table shows you, in the stage 1A and 1B, the overall survival is close to 50%. As it advances to stage 2, it is around just 35 to 25%. And the locally advanced, the 3A and 3B, it's less than 20%. And stage 4, it's only 5%. So with the advent of the EGFR, anti-EGFR TKIs, the 5-year survival improved to around 15%. But still, it is not good enough. So we are looking for better targeted therapies and better, more biomarkers, what other treatment options can be given. So in general, if you look at the non-small cell lung cancer in the 4th stage 4, how our treatment approach is based on the biomarkers. So it's very important we do a molecular testing with the testing for EGFR, ALK, ROS, BRAF, and also we do the other things like KRAS and PD-L1 is a must. So as this flow chart shows, this is from the ESMO. So if there is a sensitizing EGFR mutation, then you can use any of these TKIs, that is the erlotinib, afatinib, geftinib, dacometinib, or a combination of the erlotinib and ramucirumab as per the RELAY trial. Or you can go first line with the osimertinib. If the patient is doing well, or patient is having progression, any signs of clinical progression, or the PET scan is showing progression, then you need to do a testing for the T790M mutation. If T790M mutation is there, you have to use the osimertinib. And then depending on how the patient does, you decide the next line of therapy. If there's an ALK rearrangement, which is looked by IHC, you go for alectinib, brigatinib, ceritinib, or crizotinib. And again, look at if they have brain metastasis or if they are very symptomatic, then probably you can go for lorlatinib or a chemotherapy in the upfront setting. If it's ROS1 rearrangement positive, then you go with crizotinib or ceritinib or lorlatinib. BRAF, you have dabrafenib, tremitinib. And if it's PD-L1, anything more than 50% or 1 to 49%, you can go ahead with no biomarkers. You can go ahead with the immunotherapy of pembrolizumab or the atezolizumab. The important thing is if there is a biomarker, then target the biomarker rather than giving the immunotherapy. So as the NCCN also says the same thing, for anything with sensitizing EGFR mutations, you go with the EGFR, anti-EGFRs. And if it is discovered, already you have started the systemic therapy, you complete your planned systemic therapy, and then change to maintenance with the anti-EGFR molecule. So there are different generations of the EGFR tyrosine kinase inhibitors. So we know the first line, the gefitinib, erlotinib in the first line. In the second line, you have the afatinib and the dacometinib. And in the third line, TKI of the osimertinib. So they have the various activity as it has been depicted in this cartoon. So the first line TKI, the first generation, erlotinib and geftinib has activity more against the wild type EGFR and to some extent against the mutant EGFR. It is a reversible inhibitor binding to the wild type and the mutant EGFR. It has no activity on the T790M mutant. If you look at the second generation, which is a more potent, afatinib and the dacometinib, it acts against the family of the her family blockade, that is the EGFR. It blocks the HER1, HER3, and the HER2 to some extent. And it has a irreversible covalent binding. It also inhibits all the entire group of the family of the ERBB family. And it has a broader activity. Therefore, they have the resistance development is little lesser, slower, but we see that it has more toxicity and is not that well tolerated compared to your first generation TKI or the third generation TKI. The osimertinib is the only third generation TKI, which has a EGFR mutant specific inhibitor. It has specific activity against the T790M, and it is also the wild type sparing, the EGFR wild type also it has activity. Again, it is active by the irreversible covalent binding to the mutant EGFR. Now, the first role of the anti-EGFR or the tyrosine kinase inhibitors came from the IPA study, that is the geftinib molecule. So they enrolled around 1,200 patients, and it was mainly done in the Asian population. All patients of stage 3B or 4 non-small cell lung cancer with adenocarcinoma. Most of them were non-smokers or light ex-smokers. And they were randomized 1:1 into the standard of care, that is the carboplatin with paclitaxel versus gefitinib, 250 mg per day was given. And the endpoint was the 12-month primary PFS, secondary endpoint being the overall survival. So if you look over here, it showed in this overall population, the superiority of the gefitinib compared to the chemotherapy. You can see the separation of curves as the time advances beyond 12 months. And the p-value was significant, less than 0.01. So the 12-month PFS was 25% versus the 5.7 versus 5.8 months PTN PFS, with 12-month progression-free being around 25% versus 7%. You can see the separation of curves. So it said definitely that gefitinib had a better PFS advantage compared to your standard of care, that chemotherapy. So this was the milestone study for the advent of the tyrosine kinase inhibitors. And if you look at the mutation status again, it showed you patients who were EGFR mutation positive only had the benefit. If you gave the gefitinib in a patient who was EGFR mutation negative, it actually did harm to this patient. You can see this. The one in the green is for the gefitinib arm, where you can see in the EGFR mutation positive, you can see the suppression of curves and doing well. Whereas for patients who had EGFR mutation negative, actually the chemotherapy did better. What about the overall survival? The overall survival, it didn't show any difference. It was 21.6 months versus 21.9 months. You can see there's no suppression of curves, but the PFS advantage was there. Next came the phase 3 trials of erlotinib and afatinib. So for erlotinib, you have the optimal trial and the UTAC trial, and the afatinib, the Lux Lung 3 and the Lux Lung 6. So this showed that this benefit of tyrosine kinase inhibitors is sustained, and it is the PFS advantage is continued, and also there may be overall survival advantage. So in the metastatic lung cancer, the erlotinib, as per the optimal and the UTAC trial, in the optimal erlotinib versus the, again, standard of care gemcitabine with carboplatin, the PFS advantage of 13.1 versus 4.6 months. In the UTAC trial, erlotinib versus again cisplatin with either docetaxel or gemcitabine, 9.7 months versus 5.2 months. Both of them, the overall survival, there was no advantage. There was probably a little slight improvement, but it was not statistically significant. Next, with the Lux Lung 3 and Lux Lung 6, where you are using a second generation TKI, that is afatinib, which was a more irreversible blocker and was more potent. It completely blocked the ERBB family of blockade, but they saw a good PFS advantage. You can again see here the Lux Lung 3 saying 11.1 months versus 6.9 months. And in the Lux Lung 6, again, you can see the wide separation of curves, 11 months versus 5.6 months with a significant p-value. But what we found in our clinical practice is that afatinib had a lot of toxicities, so our patients didn't tolerate it very well. We had to do a lot of dose reductions, and many a times the patients were not very compliant with it. So we had trouble using it actually in the clinical practice. If you look at the overall survival, again, overall survival, there was no significant difference. It's overlapping. Then came the Lux Lung 7, where they looked at afatinib versus gefitinib in the first line. Again, if you look at the median PFS, 11 months versus 10.9 months. So there is no, you can't say one is better than the other. But we see that the, as per the patient's compliance and the quality of life, we continue the treatment. Then came the Archer trial, where they looked at dacomatinib, again another second line TKI, versus the first line gefitinib. So here again we took patients of stage 4 non-small cell lung cancer. So again, they were not exposed to prior EGFR TKI or any other TKI, and they should not have had any brain mets. All patients with ECOG performance status of 0 or 1. Now they stratified based on again the ethnicity, either Asians or non-Asians, and the EGFR mutation type. We know that now we have the EGFR mutation 19 and exon 21 L858R, where mostly we have the benefit of the TKI, the first line or the second line, the second generation TKI. And they looked at the PFS and the OS. Now the results of this were, they found that the PFS and OS was both superior with dacomatinib compared to gefitinib. So for the PFS, it was 14.7 months versus 9.2 months with a significant p-value of 0.01. And if you look at the overall survival also, it was 34 months versus 26.1 month. In this trial, the important thing is, again, though there were no brain metastasis patient included, and patients with metastatic EGFR who had brain metastasis at diagnosis, they usually had a poorer prognosis. Now, again, we know in clinical practice, the second generation TKI, even dacomatinib, is a little more difficult for us to manage the patients. So still, was there a better drug? So this here, again, you look here, the PFS, this is the PFS at what I told you, the PFS benefit. It was 14.7 versus 9.2 months, but OS, there was no advantage. In the PFS, again, most of in the forest plot shows all favoring towards the dacomatinib versus the gefitinib. Overall, however, there was not significant difference. 41 months versus 33.6 months. So it was not statistically significant. So what are the outcomes of a first-line TKI therapy now? So you can either use the gefitinib, erlotinib, afatinib, or the dacomatinib. If you look at the overall response rate, all of them have close to a response rate of around 55 to 70, 80%. Highest you see with the erlotinib in the optimal trial. And the least you see is with the afatinib in the Lux Lung 3. Probably this is because of we do not know the compliance or the number of months the patient has taken it. If you look at the PFS again, the PFS, most of them ranges from around 10 months to around 14.7, 14.5 months. Highest we get over here is with the dacomatinib, the 14.7 months, followed by the optimal as 13.1 month. Median OS in all these trials is not significant. So the first and second generation TKI showed a significant PFS benefit, but none of them showed any significant OS benefit. Now let's look at the tolerability profile. So if you look at the tolerability, again, erlotinib, relatively well tolerated. Most of them will have any grade of diarrhea. Grade 3 or grade 4 is very few, less than 5%. Again, rash only around 13% of cases. But if you look at the Lux Lung 3, look at this. You see 95% any grade toxicity of diarrhea, 89% of rash. And if you look at again grade 3 or grade 4, almost 15 to 68% of diarrhea or rash. And also they will have more of paronychia. Dacomatinib, again, any toxicity of diarrhea, 87%, rash around 49%, with grade 3, grade 4 around 10 to 20%. Whereas if you look at the gefitinib and the erlotinib, here again it is less. The grade 3, grade adverse 4 adverse event is relatively less. So if you look at the patients who are on second generation TKI, patients leading to discontinuation because of the toxicity is around 8 to 10%. So if you look at the first and second generation, they have a significant PFS benefit, no statistically significant OS benefit. The median PFS is around 9 to 14 months. And as I already mentioned, increased toxicity with the second generation, that is the afatinib or the dacomatinib compared to your first generation. So do you have something better for this group of patients? Then, so this kept the study with FLORA data presented in the ESMO 2019, where they looked at osimertinib versus the first line, in the first line treatment versus the standard of the first line, first generation EGFR TKI. So it was a double-blinded study where they again involved patients with exon 19 deletion or L858R mutation. Stable CNS mets were allowed. They should not have been having any prior systemic therapy with the EGFR TKI therapy. They were stratified based on their mutation status and the race, Asians or non-Asians, because we know the studies have shown that the Asians have more amount of EGFR mutation positivity compared to non-Asians. They were randomized 1:1 to give osimertinib 80 mg orally once daily compared to either gefitinib 250 mg once daily or erlotinib 150 mg daily. And they were all, so you had 279 versus 277 patients. At the end of, they were assessed at the end of 6 weeks with the RECIST criteria for looking for the objective response rate and any progression. A crossover was allowed for the patients in the comparator EGFR TKI because if the patient had any progression or T790M, then they could cross over. So if you look at the baseline characteristics, well matched. If you look at the Asian and non-Asian, see predominantly almost 62% of them were Asians in both the arms. CNS mets, around 19 to 20% had CNS mets in this group of population. And majority of them were all adenocarcinoma and EGFR either exon 19 or L858R exon 21 mutation. If you look at the primary analysis of the PFS, you can see this wide separation of curves where it shows a clear advantage for the osimertinib versus the first generation TKI. And in the forest plot also, it shows all for all the parameters favoring towards the osimertinib versus your first generation TKI. Let's look at the CNS mets. Here again, yes, it shows a benefit for osimertinib versus your first generation TKI. If you look at the PFS in numbers, it is 18.9 months versus 10.2 months with a significant p-value of 0.001. Now just let's look at the CNS PFS. So if you look at the CNS PFS, again in this, there is a clear advantage for patients who have CNS, already had CNS mets at stable mets at this thing. So the hazard ratio is 0.48. So, and the median follow-up of with around 12.4 months, saying the patients who hire on osimertinib had a 52% chance less of developing a CNS mets. So again, this had a benefit for the osimertinib versus your first generation TKI. If you look at the patients who were on osimertinib, the progression of the CNS mets was much delayed. So the patient who already had a CNS mets at trial entry, so for them having a CNS progression was around 43 in the first generation TKI, whereas only around 19 in the patients who were on osimertinib. So almost 50% higher in the first generation TKI are using as treatment. If you look at the overall survival again, you can see a separation of these curves. So it was 38.6 months versus 31.8 months with a p-value of 0.046. If you look at the forest plot here, all the parameters favor osimertinib versus your first generation TKI. Specifically, if you look at the CNS mets, again, patients who had CNS mets did well. Patients who didn't have CNS mets also did well. Patients, if you look at the Asians or the non-Asians, more of the non-Asians did well compared to the Asians. This is probably because of the earlier first generation they would have received and they had a crossover, probably that is the reason. So if you look at the subsequent, the next thing is, what is the time frame for the subsequent treatment or the subsequent endpoint, that is a death? Patients who were on osimertinib, continuing the first line treatment was at a higher number compared to your first generation TKI. So at the end of 12 months, 70% continued osimertinib, whereas 47% on the first generation TKI. And at the end of 2 years, 42%, a good number, was 16% only. And at the end of 3 years, 28% continued osimertinib versus only 9% were continuing treatment on first generation or any other TKI. And the time to first subsequent treatment also, if you see, the time interval was much delayed for the patients who were on osimertinib compared to the patients who were on the first generation TKI. It was 25.5 months versus 13.7 months, saying patients on osimertinib, the progression was much slower and much further. Now, this was published in the ESMO Congress at 2019, where they looked at around 180 patients in the second line treatment who received EGFR TKI. And they saw that around 47% of the patient had crossed over to the osimertinib arm. So if you look at this, in the first line, 47% received osimertinib, and the subsequent treatment around 68%. Whereas here in the comparator arm, around 65% received your osimertinib because they had received the crossover design and they received osimertinib in the crossover design. Now, looking at the adverse events, the median duration of exposure for the osimertinib was around 20.7 months versus 11.5 months for the first generation. And if you look at the adverse events, the most common adverse events were diarrhea and rash versus acne. So it was relatively similar, both arms. The serious adverse events were a little more in the first generation versus the third generation TKI. So it was relatively well tolerated, the third generation TKI, compared to, it was comparable to your standard of the first generation TKI. So with that, it showed a FLORA trial showed a statistically significant and a meaningful improvement in the overall survival for patients who were treated with osimertinib. The median OS was better in the osimertinib arm was 6.8 months. And this established the standard of care for the FDA gave approval for first generation EGFR TKI. First line EGFR TKI of third generation osimertinib in patients who had non-small cell lung cancer stage 4. Even patients specifically for patients with CNS mets, because you see the CNS progression is a much better control. And at the end of 3 years, almost 28% of the patients were continued in the osimertinib arm versus only around 9% in the first generation TKI. The toxicity profile also was favorable for osimertinib. So with this, the FLAURA, the final OS analysis of the FLAURA, it reinforced that osimertinib is the standard of care for the first line treatment of patients with EGFR mutation, advanced non-small cell lung cancer. So if you have any questions, we will take up the questions. I think.
Thank you, Dr. Smith. I have plenty of questions, but hopefully I'll get a chance to ask them in the panel discussion. But one thing, which I'm dying to ask, given you're at the highest volume center, any experience on using Dacomit and any reason why you would pick that at any point of time?
So I think.
Yeah, I think I had the same question. Thank you for asking.
Brilliant, Vivek.
I think dacomatinib, we have used a very few patients, a very few numbers. So probably patients who are MET or RET mutation positive, there's a role of using dacomatinib. And specifically, the PFS advantage is good with it. But from what I have seen, the patient, the clinical profile and the compliance with the dacomatinib, it's a poor molecule to be handled. So most of the patients who received it, and what I've generally heard from the other oncologists also is, it's not a very easy drug to use.
I think
If you see the
that's very
if
fair.
you see the forest plot for even the FLAURA trial for L858R, the benefit compared to exon 19 is very different. So, and dacomatinib, I think, claims that their response to L858R is better. So I think, unfortunately, the adverse events prevent us. Nobody has any experience using it and how to manage it.
Vivek, if I may, I will ask you about this in the panel discussion. So do hang around.
Okay. All right. Okay.
Because this is a big part of my own discussion. But I will not let you go off the mic right now. Next, you are on the spotlight. It's my pleasure and honor to invite Dr. Sai Vivek, the consultant medical oncologist at Astra Hospitals in Bangalore, for the next talk. Dr. Sai Vivek, over to you, please.
Yeah. Thank you for the organizers for this wonderful opportunity. And after those two excellent talks, I think we are slightly jumping into the adjuvant setting. So if I may share my screen, just 1 second. So we'll be talking about osimertinib in early EGFR mutant NSCLC patients, and with a focus on the ADAURA trial. So we all know that only 1/3 of our patients of lung cancer present to us in stage 1B or localized early stage, and loco-regional or advanced constitutes almost 2/3. And this is Western data. If you actually go through certain Indian statistics, which I went through, it is way lesser than that also. So operatable lung cancer in most of the centers in our country, which everyone would agree would be less than 30%. Just operable, I think, would be even less than 20% in most of our centers, with certain exceptions, of course. And lung cancer, as we know, is the leading cause of cancer death, and it accounts for as many deaths as breast, prostate, and colorectal cancers combined. And NSCLC constitutes 85%, with an estimated 30% of patients presenting with resectable disease at diagnosis. But in Indian subcontinent, it is way lesser than what the numbers indicate. So the outcomes vary greatly between each stage in lung cancer. The 5-year recurrence rate for stage 1B stands at 45%, and for stage 2 it goes to 62%, and for stage 3 it is almost 80%. And this goes on to highlight the importance of early detection and curative treatment strategies, so that we can offer the highest prevention for recurrences. And surgery is the primary treatment for patients with early stage NSCLC, and adjuvant cisplatin-based chemotherapy, as we all follow, is the standard of care for stage 2 to 3A with certain patients in 1B also. So from 1B, we all give it. And results from large randomized trials and meta-analysis clearly show us the benefit of adjuvant chemotherapy with a good hazard ratio of 0.89 and a DFS hazard ratio of 0.84. So overall, the disease recurrence or death following surgery and adjuvant chemotherapy remains high across all disease stages. And this presents us with an unmet need about how do we combat this problem. And based on a limited number of studies, the prevalence of EGFR mutations appears broadly similar across all disease stages. We had an excellent talk about it in the metastatic setting, and we all know that amongst Asians, it is higher than the Caucasians, and the prevalence is around 30 to 40%, the classic being young, non-smoker, women, and we all see it very commonly in our OPD settings. With that said, so ADAURA is the trial, a phase 3 double-blind trial, which used osimertinib after a curative resection with or without adjuvant chemotherapy and showed amazing results, which we'll be discussing in the next few slides. This was published in 2018 in the Clinical Lung Cancer Journal. And as I was saying, it's a phase 3 double-blind study, and patients with completely resected stage 1B, 2 and 3A NSCLC with or without adjuvant chemotherapy were included, and patients with non-squamous exon 19 deletion or L858R were taken up after brain imaging to prove that there were no brain metastasis. And the maximum interval between surgery and randomization was 10 weeks if adjuvant was not planned, and 26 weeks with adjuvant chemotherapy. 4 cycles of cisplatin-based chemotherapy was what was recommended, and a good number, that is almost around 680 patients, were randomized to receive osimertinib 80 mg once daily versus placebo, and the treatment duration was 3 years. So the recruitment was from 2015 to 18, and the first results were published in 2019, and the latest update came in 2022-23. So the primary endpoint of this was DFS, and the secondary was DFS in the overall population. The primary was mainly DFS in stage 2 and 3A patients, and designed for superiority under the assumed DFS hazard ratio of 0.7. We can see in the next few slides how it really surpassed that. So secondary was DFS in the overall population at 2, 3, 4, and 5 years. OS was a secondary endpoint, and other health-related quality of life parameters, as is the standard nowadays, were also looked into. So following the IDMC recommendation, the study was unblinded early due to the amazing efficacy that was seen, and the first unplanned interim analysis was reported in 2019. We just went through the inclusion criteria 1D to 3A after central confirmation of exon 19 or L858R EGFR mutation. Standard post-operative adjuvant chemotherapy was platinum-based for 4 cycles maximum, was allowed but not mandatory. Complete surgical resection of the primary NSCLC and recovery was needed. So patients who had only segmentectomies or wedge resections were excluded. The CT or MRI of the brain was needed prior to surgery. Both the groups were well balanced, as we see here, and according to the staging, most of the patients were in 2 and 3A, almost 70% were in 2 and 3A in both the arms, and EGFR mutations almost equally balanced at 55-45, more 55 with exon 19 deletion. And adjuvant chemotherapy, that is what is very important here. Adjuvant chemotherapy was given to only 60%, and 40% of them did not receive adjuvant chemotherapy and directly went on to osimertinib. Here we see, this is, I think, a sight for all the oncologists. The curves separate early. This is the DFS probability curves. This was the updated results. The curves separate early, and the median DFS was 65.8 months versus 21.9 with a hazard ratio of 0.23. So these hazards, yes, it is an adjuvant trial, agree, but a hazard ratio of 0.23 can never be I think misleading. Such hazards will definitely probably lead to good OS when it matures. And this was the DFS probability of the ADAURA trial, and updated primary analysis in overall population. This was for stage 2, 3. That was the primary endpoint. In the overall population, it still maintained the efficacy, and the hazard ratio was at 0.27. And this was updated after 48 months of follow-up. The 4-year DFS was consistent for the osimertinib arm across disease stages. 1B, the hazard ratio was 0.41. 2, it was 0.34. So as we go along to stage 3, the hazard ratio drops to 0.2 with the 4-year DFS percentage of 65 versus 14%. So that is something we need to take note of and realize the importance of counseling and testing our patients who had resectable lung cancer for EGFR mutations. And such a forest plot where all the subgroups are so far away from the cutoff point. And one thing to note here is, again, exon 19 had a better efficacy compared to L858R. And in spite of chemotherapy being given, though chemotherapy did add an extra benefit, as is more logical, even the arm without chemotherapy, the set of patients without chemotherapy also did equally well. And stage 3, as we have just seen, had a higher benefit. And this was the overall survival chart, but it is too early, as we can see here. Here again, both the arms, it wasn't reached, the number of events hadn't occurred, and the hazard ratio is 0.4, but I think we still have to wait. Patients and investigators still remain blinded to treatment in order to facilitate assessment of OS at maturity, and this was at 2020. And now, it is not that other TKIs were not tried in the adjuvant setting. So they are almost, erlotinib was tried and geftinib was tried. In the SELECT trial, stage 1 to 3A, adjuvant erlotinib was tried after adjuvant chemotherapy plus or minus radiation. It also showed excellent DFS of 88 versus 76% of historical control, but long-term, it didn't come into clinical practice. Again, RADIANT, erlotinib versus placebo, there was a very meaningful DFS improvement in the EGFR mutant subgroup. And even the EVEN trial, where erlotinib versus adjuvant chemotherapy, there was a DFS benefit. And adjuvant CTONG 1104, there was a DFS improvement, but there was no OS improvement. Even the BR19 study, where geftinib versus placebo after chemotherapy, if received, actually did not show any DFS or OS benefit, but none of them have translated into an approval or change in clinical practice yet, except for the ADAURA trial, which all of us are following. Now, apart from the benefit there, what all of us know that adenocarcinoma and lung cancer patients usually tend to relapse in the brain. So the pattern of relapse or where they relapse has a very important stature in our thinking when we have to decide for this. So local versus distant recurrence, if we start looking at it, local or regional recurrence is usually associated with longer post-recurrence survival than distant recurrences. And the CNS is a common site of distant recurrence among patients with EGFR mutant NSCLC receiving EGFR TKIs. In the adjuvant RADIANT study, 37% of recurrences with patients had CNS involvement. And osimertinib, as we have seen in the metastatic setting, has clinically very significant exposure in the brain compared with all the other TKIs and has shown a greater penetration of the blood-brain barrier. In the advanced setting, first line has osimertinib has already demonstrated superior OS and a 52% reduction in the risk of CNS progression. And this has definitely translated into the adjuvant setting also. So if we go through the type of disease recurrences, 11% of patients in the osimertinib arm had DFS events, that is disease recurrence or death, versus 46% of the patients in the placebo arm. In the osimertinib arm, the majority of the patients had a recurrence in the local or regional areas only. And this is usually translated into a better survival compared to distant, with only 38% of the patients having metastatic recurrence compared with 61 in the placebo arm. That is almost 50% less distant recurrences. And as we go on to the CNS also, we will go through it in the next few slides. But if you see what was the most common sites, the most common sites were lung, lymph nodes, and CNS. But if we see there, 11 versus 6 of CNS in the placebo versus osimertinib arm. And most of the patients in osimertinib had lung followed by lymph node recurrences. And the CNS DFS events in stages 2 and 3A, what we clearly see is in patients who had a CNS event also, osimertinib definitely prevented them way better than placebo. And what we are going to see here is the safety summary. If we go through it, we already know about it. Osimertinib is one of the safer and easily tolerable TKIs compared to even the other drugs that we use in the MBC setting. There were definitely more toxicities in the treatment arm compared to the placebo arm. The most common grade 3 were diarrhea, followed by stomatitis, skin paronychia, and this was the most common thing seen in the osimertinib arm. Now, if we go on and deep dive into what happened and what were the pattern of CNS recurrences, and also what happened to people who received chemotherapy, were there any differences in the people who received chemotherapy versus people who did not receive chemotherapy? So overall, 60% received adjuvant chemotherapy for a duration of 4 cycles, and the majority of the patients received platinum-based chemotherapy, with most for stage 2 and 3A disease. And adjuvant chemotherapy was more frequent in patients aged less than 70 and more in patients enrolled in Asia, and was not influenced by the performance status. And amongst this 60% of the patients, there is definitely a more benefit if used after chemotherapy. But even if given without chemotherapy, the magnitude of benefit still remains very strong. So with adjuvant chemotherapy, we clearly see a hazard ratio of 0.16, and without adjuvant chemotherapy, we see a hazard ratio of 0.23. But both these curves have very wide separation, and we know that adjuvant osimertinib can be given in exceptional circumstances. If you want to avoid chemotherapy, it could become an option. Now, in DFS, in patients with and without adjuvant chemotherapy, if we see the different subgroups here, we see in stage 2 and 3A with adjuvant chemotherapy and without adjuvant chemotherapy, they're nearly similar. In stage 1B, again, we see that chemotherapy really did not make so much of a difference. But in 3A, if we see with adjuvant chemotherapy, the hazard was around 0.13, and without adjuvant chemotherapy, it was around 0.10. So DFS in patients with and without adjuvant chemotherapy, the same thing that we have seen. So did not really make a difference in stage 1B, but when we come to stage 2 and stage 3, adjuvant chemotherapy did make a difference in terms of the magnitude of benefit. So 0.15 versus 0.20, yes, it is not too statistically significant there, but there is a definite difference when it comes to stage 2 and stage 3A. Chemotherapy does have some amount of benefit. So the patient-reported outcomes, most of the patients did not find it too harsh to take osimertinib for 3 years. So 3 years was the duration here. The health-related quality of life health surveys, SF36, where the major components were physical component and mental component, clearly showed over time the compliance rates were similar in both the osimertinib and the placebo arm. And the time to deterioration of physical and mental component, as we see here, were also very similar between both the arms. So the ADAURA trial, they summarized that in the updated DFS analysis, patients have been followed for a further of 2 years. From 2019, again, after 2 years, they had released the update. Overall, there was a 77% reduction in the risk of disease recurrence or death with adjuvant osimertinib versus placebo in the primary endpoint of stage 2 and 3A population. The median DFS was tripled at 65.8 months in the osimertinib arm and 21.9 months in the placebo arm. There was also a 73% reduction in the risk of death or recurrence in the adjuvant osimertinib versus placebo in the overall population. And the improvement of DFS was seen regardless of whether patients received adjuvant prior chemotherapy or not. And the DFS benefit across stages was consistent. When they updated the staging as per the 8th edition. So when the trial was started in 2015, and used the 7th edition, even after updation where some people went into stage 1, it really did not matter. So osimertinib demonstrated a clinically meaningful improvement in the CNS DFS, which was very important. So one thing that I was going through was, while on therapy, only around 3 patients on the osimertinib arm had a recurrence, and that too in the CNS versus 18 in the placebo. So we don't know after 3 years what is going to happen, at least for the first 3 years, especially in stage 3, where we know the recurrence rates are almost 65 to 70% recurrence rates are there in stage 3 after resection and chemotherapy. Preventing it for a span of 3 years, 3 versus 18 is a very significant difference. So 18 of them who had a recurrence in the placebo arm had it in CNS versus 3 in the osimertinib arm. So thank you.
Thank you, Dr. Sai Vivek. That was such a lucid talk, and I will try and get all our all your comments on this. And we've got a whole legion of experts joining us. Organizers, can you please allow me to share my screen? Thank you. So we have with us a very august company. I mean, this evening Zoom meetings are a little bit like Times of India, or sorry, Arnab Goswami's news debate channels. We have the doyens of our field with us. Let me start with Dr. Rahul Sood, Wing Commander Dr. Rahul Sood, who's the Professor HOD at Command Hospital. Sir, are you with us?
Hi, Dr. Aditya. Very well. I'm here. And good
Fantastic.
evening to all.
Fantastic. Karthik sir, Dr. Karthik Udpa, are you with us, sir?
Yeah, Aditya, I'm there.
Fantastic. And can I request Dr. Abhay, Dr. Smita, Dr. Sai Vivek also to join with us, please?
Yes, Dr. Aditya, we are here.
Okay, fantastic. Let me just, before I just start off, we've got a whole list of talks over here. More importantly, I think for all of us, the biggest questions that we have here is what do we do with the NGS? And I would like to talk a little bit more of the NGS also. Dr. Lepakshi, have you joined us? Lepakshi, are you with us?
Yeah.
Fantastic. So before I dive into the case, given the fact that we have heard from our previous speakers, Lepakshi, in your own practice, given the fact that you also come from a fairly high volume center in Mangalore, how do you decide which patient to send for NGS? I know we have a case history and I'll discuss that later, but I think for us, for me personally to learn, one of the practical points is, what do you see? Do you see a DNA versus an RNA? Do you see things like 50 genes, 100 genes, 350 genes? How would you see that, Dr. Lepakshi?
Yes, Aditya, because ours is mainly patients come from the North Karnataka region, and majority are this middle class and BPL. So majority of them, we won't go for the 12 gene NGS panel. So we usually ask EGF for all cross only. But if the patient is affordable, definitely NGS 12 gene panel. So we are going to offer.
Okay, great. So let me start off with my case. We have a 54-year-old patient who is a former smoker but has got 20 patient years of smoking history over here. He presented with some pleuritic chest pain and some shortness of breath, fairly vague symptoms which most of us see in our clinic. The CT scans were done that showed a left lobe pulmonary mass which was about 4.2 to 3.7 centimeters. Unfortunately, there were right adrenal gland metastasis, and a biopsy was done which showed it was adenocarcinoma, so this was stage 4 non-small cell lung cancer. Let's not debate on the PET scan versus CT thing over here. Let's assume that we've all done a biopsy and we have sent for, as Dr. Lepakshi said, and in my own personal practice, we do try and look for either the reflex testing or more recently look for the shortened specific panel. So this patient had a L858R mutation. Let me start with Dr. Rahul Sood. Dr. Rahul Sood, what would your treatment of choice for this patient with the L858R mutation be? Your choices are on the screen, sir.
Yeah. So I think
all are excellent choices, but I think the third generation TKI is one thing that I'll prefer. The other thing is, if the performance status of the patient is very good, the Tata trial of chemotherapy with Geftinib is also another option. So I think if I'm given two options, these are the two options. If only one, then I'll go with third generation TKI.
Dr. Karthik, over to you. Let's keep finances aside. Osimertinib versus chemo plus Geftinib. What would you pick?
I think I'll go with osimertinib and chemo plus Geftinib. I have given it with good response rates, but I think my first preference will be osimertinib. And dacometinib is not a bad option if the patient has a tight pocket. Maybe dacometinib is a good option in this mutation.
Can I ask you to little bit talk about your dacometinib experience, because neither me nor Sai Vivek have too much of experience on that. So how has your experience on dacometinib been?
Dacometinib, I think for this, that's Exon 21. I've given it for few patients, not with the full dose. Maybe I think it is, I have given 30 mg, and the response rates are pretty good. So I don't have a head-to-head trial with, let's say, Geftinib versus dacometinib or osimertinib with dacometinib, but they are fairly doing okay. And whatever limited patients, I have 2-3 patients, they are tolerating this dose also.
Okay, and you've given them obviously for fairly long time, so you're not very worried about 1 year. What happens at 1 year or a year and a half point, is it?
Yeah. I mean, see, I think EGFR mutation per se, it's a good thing to happen for the patient. Usually you start with Geftinib also, you would have seen in your experience that patient will probably go on for more than a year time. But Exon 19, I mean, is a better mutation to have, and 21 is not that great. So 21, if it is there, I discussed the option of dacometinib, because it has clearly shown that for this mutation, that is Exon 21 L858R, it's comparatively better compared to maybe Geftinib. But if the patient can afford osimertinib, yes, of course, I would love to give osimertinib.
Thank you, Karthik sir. So next question to Dr. Abhay. Abhay, are you around?
Yeah.
Dr. Abhay, so this one's for you. What are the considerations when you're choosing your first line option in the clinic? QOL, OS, safety, efficacy, which would you pick, and which order would you pick this?
Yeah, almost all are important, but first preference is survival. So obviously efficacy follows, quality of life follows, safety follows, but all these are important.
So in this, I will try to put you on the spot over here. I agree with you with all of these options, but do you think there is a problem with using dacometinib in terms of QOL or safety, or would either of those factors influence your choice of the TKI?
Obviously, first preference is based upon overall survival, then safety, then tolerance.
Okay, fantastic. So when we look at efficacy, most trials had PFS as a primary endpoint, and this is like a distant measure of the drug's benefit. The initial trials had the Lux-Lung had afatinib versus Geftinib. There were some investigator-initiated trials of erlotinib versus Geftinib. There's a Japanese trial about erlotinib versus Geftinib. Archer 1050 looked at dacometinib versus Geftinib. Flora, as Dr. Sai Vivek said, as Dr. Smita said, looked at osimertinib versus erlotinib or Geftinib. Osimertinib really set a new precedent and a breakthrough benchmark for TKI therapy to deliver a PFS benefit of about a year and a half. And mind you, we are talking about stage 4 lung cancers. Even in our own clinical practice, we have seen that the trial data has very well translated into real world settings. 15-18 months is something that I'm very comfortable discussing with our patients in the clinic. Next question to you, Dr. Smita. Will the type of mutation change your choice of EGFR TKI, especially given the fact that Dr. Karthik has also discussed this? This is a question which I want to debate on for a bit. Dr. Smita,
I think definitely the type of mutation will definitely alter our choice. So if it is exon 19 or exon 21, we go ahead with the first generation. And as I think The exon 20, we will not give you our first generation or the other regular TKIs because there's no benefit. I think, as he said, for exon 21, probably the decomatinib has better benefit, but our usage has been less.
So,
Yes.
Smita, to sort of put you on the spot over here, let's ignore exon 20 for just one moment. Exon 19, some people say that third generation is better. Some people say 21 is better. Where would you place this? We know that there is another combination of erlotinib with ramucirumab. Where would you place this combination of Arlo ramucirumab? Have you had any experience, and when would you pick if you are given a choice?
I think the rarer mutations in the exon 21, there you would prefer to use a combination of the relay trial, because definitely that relay has shown the best PFS advantage. But Erlo with ramucirumab, but usually third generation, if a patient has CNS mets, the other clinical parameters are going to help us decide the the choice of TKI.
Can I come to you, Dr. Lipakshi? What is your thoughts on this, please? Lipakshi, are you around? Can you hear me?
Yeah, Dr. Aditya. So if the patient is affordable, my first choice is osimertinib only, irrespective of whether it's exon 19 or exon 21. And suppose if the patient is not affordable exon 21, then I may offer either gefitinib with chemotherapy or erlotinib with bevacizumab.
Fantastic. Thank you, Lipakshi. I think that's a very straightforward this thing. Dr. Abhay,
Wait,
your
wait.
thoughts on this? 19 versus 20, Arlo ramucirumab versus osimertinib.
Yeah, 19 versus 21. So whether irrespective of one of these two types, osimertinib is the way forward for me.
Dr. Rahul, I think we have had quite a bit of debate on this, but is there, let's ignore finances for one moment. Let's just want to give the best treatment for our patient. Any reason why you would pick Arlo ramucirumab over osimertinib at any point of time?
See, it's actually a flip of a coin if you see L858R mutation, because in exon 19 everything works. The first generation works, the second generation and third generation. Probably this is the place where we like to sequence our therapy, and these people do well with anything you give. But yes, when it comes to L858R, osimertinib, a combination of ramu with erlotinib, and even chemo plus gefitinib, they all do decently well, though the responses are not as great as in exon 19, which is there. So I think it is anybody's choice, and like people said, the performance status of the patient, we've kept the finances separate. Yes, the other toxicity profile, the preferences of the patient, whether he can come for chemo, that all takes precedence, whether he's a hypertensive or not. So I think these are three important things three important options that patients have with L858R. I'll not go with first or second generation TKIs in this subset. It will be only these three options: osimertinib, ramucirumab, or chemo plus gefitinib.
Dr. Karthik, now to put you on the spot here, you've got all three options. Money is not a problem. Dacopatinib versus osimertinib versus Arlo ramucirumab.
Arlo ramucirumab, I have not used it at all, so I don't have much experience, or rather, I don't have much of confidence on this combination. So maybe if given if for my patient, I will probably offer osimertinib as the best choice. If the patient cannot afford, the second choice will be chemo plus gefitinib. Third will be dacopatinib.
I think, a big take home from all our experts over here is that no matter what, will the type of mutation change our choice of the EGFR TKI? And on the screen, we can see data from the Lux-Lung trials, from the FLORA trials, the various forest plots. PFS was the primary endpoint in these studies and is a direct measure of the drug efficacy, be it exon 19 deletion or the L858R mutation. PFS is the longest with osimertinib. CNS Mets patients were excluded from Archer. So although Archer did show that dacomitinib might be a big differentiator, exon 21 versus exon 19, CNS Mets is going to make a big difference when we talk about EGFR mutant patients. So when we talk about efficacy or overall response rates as a secondary endpoint, even in this, osimertinib did come up trumps, and it has shown the highest overall response rate and the median duration of response. Moving over to you, Dr. Smita, how important is OS? And this is being asked to you specifically given for the fact that you do come from a sort of a resource challenge setting. And how do you counsel a patient in your practice, madam?
OS is definitely important in the metastatic setting. So with the third generation EGFR, that's the only TKI where we have seen OS advantage significant. All the other TKIs have only shown a PFS advantage. So it's very important. So we say larger number of patients of stage 4 are continuing on the treatment, and they have a better overall survival with a good quality of life. So for me, overall survival is definitely important. But for our center, I think the high volume numbers what we have, since it is still not affordable, still patients are on the first generation and doing okay.
Okay, I think Dr. Smita, there is a metric which is applied in NHS, which looks at things like the actual benefit of the treatment versus cost to the system. And I know that Andhra Pradesh government today morning only Dr. Raghunath Rao did say that he is a part of the Andhra government advisory committee. Given the fact that you are in a position of power, if you are allowed to choose a metric, like if the magnitude of benefit versus cost metric, do you still think magnitude of benefit versus cost third generation wins over first generation?
I think in the long run, definitely it will win over, because see, if you're going to get a better overall survival, a better PFS, then your going for a subsequent line of therapy will reduce. The number of complications the patient will develop, that other aspects of the healthcare, you'll have a definitely cost advantage. But I mean, unless it comes to get into the protocols will be very difficult, because they are not healthcare providers. So I think as a very difficult situation, though we try to explain it. So unless like-minded people are sitting in that group, it will become very difficult.
I mean, rightly put, Dr. Smita. When we talk about the FLAURA overall survival, although this was a secondary endpoint, FLAURA did show a benefit in median overall survival improvement. The benefit of using osimertinib, the median overall survival was more than 3 years, and we are talking about stage 4 lung cancer. Let's never forget that. Despite a crossover rate of nearly 30% observed in all the patients who were assigned to the comparator group in FLAURA, significant OS benefit was observed in the osimertinib group. Osimertinib patients were more likely to be alive at the second and the third year landmarks. When we try and compare the LUX-Lung and the Archer, statistics in clinical trials cannot be ignored. Afatinib failed to improve overall survival in LUX-Lung 7. Archer was only designed to show an OS benefit if there was a statistically significant overall response rate. So neither Archer was powered enough to look at the OS, nor the LUX-Lung did show any overall survival benefit. So the osimertinib and the FLAURA trials can confidently say that this was the only trial which showed an overall survival benefit when we talk about TKI therapies in stage 4 lung cancer. Coming back to you, Dr. Abhay, while choosing an EGFR TKI, how important is CNS metastasis consideration in your patients? Dr. Abhay? Abhay, are you?
Yeah, definitely it is very important, because we know that patients with brain metastasis have got poor prognosis, because penetration of chemotherapy is poor, and first generation, second generation EGFR TKI penetration is poor, and hence so the molecule which acts in the brain is most important. So that's why that is a very important consideration. The molecule which acts in the brain is more important.
So I think Abhay, the next question is also to you only here. Do you routinely do a brain MRI for all your stage 4 patients, even if they are asymptomatic? And this is a very practical question sitting in a corporate hospital wherein a brain MRI is going to cost 12 to 15,000 rupees.
See, ideally, according to the guideline, ideally it should be done. But since we are doing PET CT scan for almost all patients, we don't do it. Asymptomatic, I'm saying.
I think this is again something which I want all our experts to try and opine on. Dr. Lepakshi, how does your practice work here?
Yeah, Dr. Aditya, even if they are asymptomatic, then we won't consider MRI brain. So majority of the patients we are considering PET CT as a preliminary investigations. So if they are asymptomatic, we are considering MRI brain.
Sorry, you said that if they are asymptomatic, you will do MRI, or if they are symptomatic, will you do MRI?
If they are symptomatic only, I will consider MRI brain.
Okay, fantastic. Dr. Rahul, so what is your practice, sir?
So actually, my practice is a little different because the patient doesn't pay from his pocket, unlike the other corporate hospitals. So we do get an MRI done for all our patients of stage 4 lung cancer. So, and as per the guidelines, and we follow that.
Correct. I mean, you know, when we look at the data, 25% of the patients who are EGFR mutant will, so a fourth of EGFR mutant stage 4 lung cancer patients will have brain metastasis at baseline. And this is more of a practical problem. Dr. Karthik, again, a very high volume center you work in. How do you manage it, sir?
I'm trying to get MRI for most of my patients. Basically because the treatment also changes. Say the patient is asymptomatic, brain metastasis is there, and if the EGFR is positive, then probably osimertinib, we need to push for osimertinib, like borderline finances. So if the patient is unaffordable, definitely no for osimertinib, but still I try to get an MRI brain in most of my patients.
I think, you know, most of the questions on the screen you have answered, Dr. Karthik. So the question, again, the next question is, let's assume for a moment, if there are symptomatic brain metastasis, would you push your radiation oncologist to do a whole brain RT versus say, no, that's okay, let's try with osimertinib?
It depends on how symptomatic the patient is. If the patient is really symptomatic, say the patient is having excruciating headache, vomiting, altered sensorium, I try to get the RT done. But if the patient is having, say, mild intracranial hypertension, so mild headache, I start, if the patient can afford, I go with osimertinib.
Dr. Smita, how do you deal with this? And let's assume that you are able to give all of your patients osimertinib.
So I think if we are able to give osimertinib, in that case, I think we can avoid giving the radiation. Am I audible?
Yeah, very much.
So we can avoid radiation. But if it's
Okay.
very symptomatic with a lot of mass effect, multiple CNS mets, then probably there is a benefit of giving the RT. So we have a few patients where we just gave osimertinib and they did well, a patient with upfront brain mets.
So let me put in a question here, which some of our radiation colleagues do ask me every day. Patient, you've evaluated a patient, found that patient has got stage 4 lung cancer with EGFR metastasis, and patient has got some giddiness, some nausea. You get an MRI of the brain, there is some mass effect there. But you start with steroids, and in 2-3 days, the symptoms do come down significantly. Would you still consider? The other scenario that I want you to answer is, would your radiation oncologist ever say that giving radiation for a patient who already has a mass effect, wouldn't it worsen the symptoms in the immediate future?
So I think usually if it's well controlled with your conservative, the first scenario what you gave, in a patient who improves with steroids, probably if you're giving osimertinib, since it's a very good CNS penetration, we can avoid giving the whole brain RT. And as you rightly said, yeah, many a times when they already have a lot of mass effect, the radiation oncologists are a little hesitant to upfront give the whole brain RT. They say, probably get it down with your conservative management and then we will start. But most of the times, patients, if you're not using osimertinib, then we consider whole brain RT, even if it is having mass effect also.
Fair enough. Dr. Rahul, I'm quite certain your patients don't have this problem. You are able to provide the best treatment for all of the best of this nation. How do you deal with this conundrum of mass effect, no radiation oncologist not being so keen?
Yeah, so it happens very often, and this is a real life situation that we also face. Because of the mass effect, they delay the radiation, or they're not very keen. So yes, we medically manage these patients, and many times we start the patients on the third generation TKI, also osimertinib, and you see a tremendous response in the combination of the medical management with the brain mets as well as osimertinib. I have had 2 or 3 patients who've not required radiation thereafter, in fact, also. But the thing is, if the patient is symptomatic with brain mets, I think radiation should be offered to the patient. But if the patient is asymptomatic, you can wait and start your third generation TKI.
Dr. Karthik, your thoughts on this, please.
Yeah, I completely agree with Dr. Sood. I told couple of minutes earlier, I told the same thing. Symptomatic brain metastasis. Yeah, if the patient is really symptomatic, so I think it is the medical oncologist's call. So I think we can convince the radiation oncologist. I think never the radiation oncologists don't tell no to any of the brain metastasis if we tell them to give radiation. So give them steroids. If the patient has mild symptoms, give them steroids. Patient improves, start on osimertinib. But a lot of symptoms, you know that patient is not going to do well with only steroids, give them RT.
I think that is our real life answer to most of the questions. If we know that patient has got too much of meds and they're not going to do well without RT, most of us, even in the era of osimertinib, will strongly consider adding radiation because we don't want to miss out on such that modality. But all things considered, this particular slide shows that none of the EGFR TKIs do come close to osimertinib when we are talking about brain metastasis. So significant CNS response to first-line osimertinib is seen in patients with EGFR mutant advanced non-small cell lung cancer. Only the Lux Lung 7 included some asymptomatic brain metastasis. The Archer did not even include brain metastasis. Both systemic and CNS clinical benefits were observed with osimertinib. Hypothetical scenario, would PD-L1 positivity favor? I think, let me just, in the interest of time, skip this question primarily because none of our August field would even dream about starting IOs in a patient who is EGFR positive. Let me just put this through. So by and large, when we have a driver mutation, the PD-L1 sensitivity is not very relevant. Tumors with EGFR mutation in general do not respond to anti-PD-1 or anti-PD-L1 checkpoint inhibitors. The driver mutations should be tested in non-squamous non-small cell lung cancer patients, and irrespective of high PD-L1 expression, patients have to be treated with a targeted therapy. Safety profile of EGFR TKI. Dr. Abhay, you work in a corporate hospital. You don't want to get a call from the ER at 6-7 p.m. in the evening saying this patient has come back with toxicity. What would you pick here? Dr. Abhay? Abhay, are you around? Okay. Let me try and move. Dr. Lepakshi, can you hear me?
Yeah, Dr. Aditya.
How important is the safety profile for EGFR TKI? And the background for this question, if I may give you, is chemogeftinib might have a little bit more safety adverse event profile. Would that influence your decision?
Yeah, it is very important because safety profile is very important when you are treating advanced non-small cell lung cancer patients. So when we decide about the treatment, this is also one of the important parameter, especially in the advanced non-small cell lung cancer. So obviously the EGFR TKI with the least toxic profile, so we are going to up the treatment, especially So what our experience is, Gefitinib is well tolerated compared to Erlotinib. As per my experience, Erlotinib, many of my patients are not tolerated well. And when it comes to the again Afatinib also, Afatinib, many of the patients not tolerated well. Lot of diarrhea and skin toxicity or more, especially the Afatinib and Erlotinib patients. And when it comes to the Osimertinib is very well tolerated, very less grade 3 and grade 4 toxicity. And majority, what we seen it only skin related toxicity, skin and diarrhea. That also only grade 1 and grade 2. So we are, as per my experience, Osimertinib and Gefitinib, these two drugs are well tolerated in advanced non-small cell lung cancer.
I mean, Dr. Lepakshi has put it very well. Amongst all the EGFR TKIs, second generation EGFR TKIs have an unfavorable tolerability profile. Grade 3 and above adverse events are much higher with Dacomitinib and Afatinib. EGFR TKI combination therapies are also associated with significantly higher grade 3 and above adverse events compared to EGFR TKIs alone. Dose reductions due to say adverse events in the Lux Lung 7 Afatinib trials, 52% of the patients needed to undergo some kind of a dose reduction. In the Archer trial, 66, 2/3 of the patients needed some kind of a dose reduction. However, when we look at the pivotal Flora trial, the dose reduction with osimertinib was only about 4%. So this is basically a no-brainer when we talk about this. We've got 3 minutes, so the last few set of questions. Dr. Smita, this one's for you. Does quality of life matter when we are treating patients with advanced non-small cell lung cancer? And let's assume that, why assume? Let's see that you're talking about this from a perspective of treating in a high volume, low social sector setting.
Yeah, quality of life definitely matters, because only if the quality of life is good, the patients will continue the treatment and the clinician is happy, the patients are happy. So what we have seen is with the oral TKIs, the quality of life is very good compared to your chemotherapy. Though even chemotherapy, pemetrexed, the toxicities are much lesser, but still the TKIs are much well tolerated. So in that, as we rightly said, the first generation and the third generation are very comfortable to use. Second generation, most of us are a little hesitant. We go with the low dose and then start. So for me, in a stage 4, the OS is important, but the quality of life and the pain relief is equally important.
Fantastic. So when we talk about the quality of life, the global QOL significantly worsened in the Dacomitinib group versus Gefitinib as per the Archer trials. One of a big treatment goal in the metastatic setting, as Dr. Smita so rightly put out, is to improve QOL, because if the QOL is not improved, the patient will not be compliant. So it is useless to give an effective drug if it's not improving the quality of life. The very last question for all of our esteemed panelists. Let me start with you, Dr. Karthik. Dr. Karthik, when would you consider a sequencing approach?
So this sequencing, can you just elaborate on this? What exactly you mean that?
Sequencing in terms of first generation with chemotherapy, or starting third generation alone, or maybe, doing first generation, waiting for the T790M to pop in and then do the third generation.
Okay. So I think the answer is very clear. So if there is a EGFR mutation, 19 and 21, so you go with osimertinib. Right now, that has shown the maximum benefit with the great overall survival benefit. So in case the patient has, so that is my first preference. So in most of the real world scenario where the patient cannot afford this, I start with the either Gefitinib, or if the PS is good, chemo plus Gefitinib, then after 4 to 6 cycles, just continue with Gefitinib. And look for this T790 mutation. If at all it pops up, then I have to again counsel them for osimertinib. So most of the time, if the patient can afford osimertinib, if the patient cannot afford, either first generation TKI or chemo plus TKI.
I mean, very rightly put. Dr. Rahul Sood, your thoughts on here, please. How many of your patients do survive to go on to receive a second line and in a real world setting? And do you think that influences your decision in your first line management?
Yes, I think I'll say almost maybe 40% of the patients will drop out or may not have a good PS by the time you reach second line. So that means you throw the best up front, you send your best batsman up front. So so I think the performance status is not going to improve in the second line of the patient. Neither is he getting any younger. The toxicity of the first line may also add up to that. So I think you should go ahead with the best upfront. Probably third generation TKI is the way to go forward in the first line, and that is how I think
Very rightly put, real world data has shown that 7 out of 10 patients who start on the first or second generation TKI will not be able to receive osimertinib in the second line itself. And more importantly, it's not possible to predict who will develop the T790M resistance. So, I mean, there are certain people who advocate the geotag approach. Geotag is basically trying to sequence therapies in terms of trying to give first line first generation, second generation TKIs and see who of these develop a T790M mutation and then try and reserve the osimertinib molecule to this. But the problems with geotag was this was a retrospective observational study which did not include patients who died on first line afatinib, and the time to treatment failure endpoint cannot be compared to PFS as an endpoint, and OS in this was just an exploratory endpoint. So to conclude my talk over here, osimertinib resulted in a significant improvement in PFS over standard of care with a hazard of nearly 0.46. Only osimertinib demonstrated a statistically significant and clinically meaningful improvement in CNS PFS. Osimertinib is the first EGFR TKI monotherapy to show a statistically significant overall survival benefit. And most importantly, after 3 years, 28% of patients in the osimertinib arm remained on first-line treatment. Osimertinib also presented a favorable and consistent toxicity profile despite prolonged exposure. The final OS analysis of FLAURA reinforces osimertinib as the standard of care for first-line treatment of patients with EGFR mutant advanced non-small cell lung cancer. I thank you all for a patient listening, and I'm happy to take any of closing comments from our esteemed colleagues over here.
Yeah, Aditya, I just have a comment to make.
Yes,
I
sir.
think it was a fantastic moderation. So it was just like facing Arnab only, because you were very clear, very crisp, and it was to the point. So good moderation, excellent moderation. Thank you very much.
Thank you so much, Dr. Karthik. Any of our other colleagues, Dr. Rahul, so I have to ask you. Okay, no, you're not the right person. You will always, you don't have a problem with resources. You are able to answer all of these. Dr. Smita, I have to ask you here, any single moment where you would say both options are available, osimertinib versus the rest, you still prefer the rest versus osimertinib? Any single setting ever?
I think I cannot think of anywhere where I would prefer first line or second generation versus third generation.
Dr. Lepakshi, Dr. Abhay, any thoughts on this, please?
No, Dr. I will
I think
also
only
prefer
something like that, probably.
Okay, brilliant. Wing Commander Dr. Rahul, so I think your closing remarks, and we'll hand this back to the organizers, please.
I have no closing remarks. All I can say is many times we start our patients on a combination chemo plus chemotherapy when we are awaiting the NGS report. It happens in many of our patients in our hospital. And probably 2 cycles down the line, we get the NGS report and it comes as EGFR exon 19 positive. So this is the only situation where we probably start the patient on chemotherapy, try to continue it for maybe 2 or 3 cycles. And this is where we don't switch over to osimertinib. We in fact discuss such things with our patients upfront, saying that whether you want to wait for the NGS report or when should we start chemotherapy. And many of them, they say we start on chemotherapy. So this is one situation where we probably keep osimertinib in the second line or something like that. Otherwise, that's the drug to go forward So that's all.
Thank you so much, Dr. Rahul. Thanks to all my esteemed colleagues. Over to you, back to organizers, please.
Thank you, sir. I hope it has been a great evening with excellent talk and excellent panel discussion. Thank you, everyone, for joining. Good night, everyone.
Good night. Thank you.
Thank you. Good night. Thank you.
Good night. Thank you.
Support team, please end the meeting.